This is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. So today we're going to talk about a very important topic, and that is the ratio of omega-6 to omega-3 when we are taking a diet or nutritional supplements. There are a lot of studies that talk about the omega-6 to omega-3 ratio. The basic background to these studies and these data points are that in the Western diet, it is said that the omega-6, which is typically pro-inflammatory, is taken in greater amounts as compared to omega-3, which is typically anti-inflammatory. The studies show that the Western diet has omega-6 to omega-3 ratio of about 13 to 1 or even 16.7 to 1. So in that range. Now, considering that typically omega-6 is pro-inflammatory and omega-3 is anti-inflammatory mostly, the curiosity is that what is the ratio to maintain? Studies also say that the original ratio, when we used to live without these processed diets, we used to maintain a ratio of 1 to 1. Nowadays, the recommendation is to maintain a ratio of 1 to 1 to 1 to 4 or 4 to 1, omega-6 to omega-3. Having said that, I don't think that the answer is this simple and this generalizable. It really depends upon the person's own health. It depends upon their own status of the body. It depends upon their inflammatory status. So let's dig deeper into understanding that what should be the ratio, who should care for the ratio, and if you are a provider, if you are a physician, if you are managing someone, then how to think about the ratios based on what is their inflammatory state. So I'm going to share my screen and we'll go from there. So this is the lecture for today, omega-6 to omega-3 ratio. So I am not going to cover the sources of omega-3, the sources of omega-6, the benefits of omega-3 versus the benefit of omega-6. The primary topic that I want to discuss is the ratio of omega-6 to omega-3. You would see these three characters that will appear again and again: healthy individual, someone who is undergoing an acute illness and inflammation, and someone who is chronically inflamed because of chronic inflammatory disease states. So I'm going to provide you the thinking first, and then we would go deeper and understand that what is behind this thinking, what are the mechanisms behind this. So the thinking is this, that if somebody is healthy, they are not in an inflamed state, then, and we're talking about someone who is consuming Western diet, then they are consuming Western diet or a diet which presumably is giving them much more omega-6 compared to omega-3. And so their body is in a state of pro-inflammatory molecule more abundantly present compared to anti-inflammatory molecule which are lesser present. And this will become clear as we go later. However, for this healthy individual who is not inflamed, it is not immediately necessary to start taking the omegas in these ratios. However, it will be prudent for such healthy individuals to start using omegas in the correct balance for the future. And this will also become clear that why it is important for the future. That means if there is a healthy individual who is looking to understand that what should be their dietary adjustments or the supplement adjustments so that they can have a correct balance, then a balance of omega-6 to omega-6 to omega-3 of 1 to 1 or 1 to 4 is a desirable balance. And this would become clear later on. Now imagine this is the second person. This person became acutely ill. For example, they developed, let's say, SARS-CoV-2, or they developed another viral or bacterial or fungal or some other reason for inflammation. In such individuals, the inflammation that is produced is their body's response to manage the pathogen or this event that is happening. In this situation, what happens is body will produce and use lot of omega-6. And here when I say produce, that doesn't mean the body itself can produce omega-6. Omega-3 and omega-6 are both actually essential omegas. That means you have to take them from outside. Our body cannot manufacture them. So when I say it is going to produce it, that simply means that from the storage, it will cleave them and mobilize them and start utilizing them. So in an acutely inflamed person, body is trying to produce inflammation to fight with some pathogens, for example. So in that case, the body is going to try to lean towards the omega-6 molecules to use them to produce arachidonic acid, and that would help produce inflammatory molecules, which will allow the body to fight with the pathogens. In the same body, the person who is acutely inflamed, omega-3 will also be used up, but this will be anti-inflammatory, and the mobilization of omega-3 will act as a molecule that is now trying to calm down the inflammation, and this omega-3 usage might actually reduce the omega-3's levels in the body. Now, would we start worrying right away that the omega-3 is less and omega-6 is more? No, not really. It is the body which is trying to tip the balance towards inflammation to handle the pathogen. Now, should we manage this by giving more omega-3s to this patient or this person? Sure. If you are thinking that the patient will benefit from, let's say, ibuprofen or anti-inflammatory medicines because maybe their inflammation is more than it should be, then sure, omega-3 administrations will be useful as well, and a reduction in omega-6 intake will be useful as well. Then comes the more important thing, and that more important aspect of the human pathology, and that is a chronically inflamed individual. We all, as we age, we start becoming more and more inflamed. Then there are events in people's lives that occur and that put them towards a more chronically inflamed state. So chronic inflammations are an important part of the pathologies of many diseases like diabetes and cardiovascular events and strokes, etc. In this person, chronically inflamed, I am assuming that this person who is chronically inflamed or has chronic inflammation, they actually did not need this chronic inflammation. There is no triggering factor that is in need of a continuous fight. But instead, the body has pathologically become stuck in a state where the body is producing inflammation. Now, this chronic inflammation would, of course, cause tissue damage. So in this person, what should be the omegas intakes? And if you think about it with me, in this person, omega-6 must be already higher and higher used because this person has more inflammation. And omega-3 must be getting depleted because it must be trying to cool down the inflammation, but there is some trigger that is continuously helping produce the inflammation. So this person has lesser omega-3, more omega-6. In such a person, it would actually be prudent to try to increase their omega-3 levels even more than the balanced 4 to 1 omega-6 to omega-3 ratio. This person might actually just need a lot of omega-3 first. And then when they have overcome their inflammation, if they could overcome their inflammation with this management, then a balanced diet from then on, or balance between the omega-6 and 3, can continue. So this is how to think about it instead of a generalized statement that everybody should have omega-6 to 3 ratio of 1 to 1 or 4 to 1. It depends upon the person, the illness, the cause of the illness, the chronicity of the inflammation, the levels of omega-6 and 3, and then you decide. But this is a general map of how to think about it. Now I'm going to go into the details. So if you just wanted to understand how to think about this one, then here it is. It does not mean that everyone should start taking omega-6 to 3 in the ratio of 1 to 1 or 4 to 1. It actually will depend upon the state of the person's body. Now I want to quickly share Biomedicine and Pharmacotherapy. This is an article, The Importance of the Ratio of Omega-6 to Omega-3 Essential Fatty Acids. It's a beautifully written article, and I just want to read some parts of the abstract to kind of provide you that there is evidence behind what I'm talking about. So here is their abstract, and they say several sources of information suggest that human beings evolved on a diet with a ratio of omega-6 to omega-3 of almost 1. Whereas in Western diets, the ratio is 15 to 1 or 16.7 to 1. Western diets are deficient in omega-3 fatty acids and have excessive amounts of omega-6 fatty acids. Compared with the diet on which human beings evolved and their genetic patterns were established, excessive amounts of omega-6 polyunsaturated fatty acids and a very high omega-6 to omega-3 ratio, as is found in today's Western diet, promote the pathogenesis of many diseases, including cardiovascular disease, cancer, and inflammatory and autoimmune diseases. So I would like you to keep an eye on this statement, that how would omega-6 and a high ratio of omega-6 promote, I would not use the word promote, but I would say that it creates a predisposition for a body to develop inflammatory states. Whereas increased level of omega-3, a low omega-6 to omega-3 ratio exerts suppressive effect. So this is one part of their abstract. And this is a wall of text over here, but there are some very important data points that I want you to kind of please hear them out. Then we'll go into the mechanisms of this discussion. In the secondary prevention of cardiovascular disease, so somebody who had a cardiovascular problem, an event, a heart attack, and then we are trying to prevent the next event, a ratio of 4 to 1 omega-6 to omega-3 was associated with a 70% decrease in total mortality. A ratio of 2.5 to 1 reduced rectal cell proliferation in patients with colorectal cancer, whereas a ratio of 4 to 1 with the same amount of omega-3 to PUFA had no effect. The lower omega-6 to omega-3 ratio in women with breast cancer was associated with decreased risk. A ratio of 2 to 3 to 1 suppressed inflammation in patients with rheumatoid arthritis, and a ratio of 5 to 1 had a beneficial effect on patients with asthma, whereas a ratio of 10 to 1 had adverse consequences. Keep in mind that these are all states where the patient is already in an inflammatory state, and now we are trying to combat that state with changing the amount of omega-6 compared to versus amount of omega-3. These studies indicate that the optimal ratio may vary with the disease under consideration. This is the key sentence for the discussion. It depends upon the person. So there is no generalized statement to be given to say everyone should take omegas in this ratio. It will really depend upon what is their situation. This is consistent with the fact that chronic diseases are multigenic and multifactorial. Therefore, it is quite possible that the therapeutic dose of omega-3 fatty acids will depend on the degree of severity of disease resulting from genetic predisposition. A lower ratio of omega-6 to omega-3 fatty acids is more desirable in reducing the risk of many of the chronic diseases of high prevalence in Western societies, as well as in the developing countries that are being exported to the rest of the world. So generally, if you think back for the discussion I just did, that is what is here shown in evidence as well. Okay, so we have now done two things. We have looked at the clinical aspects of the ratio and how to think about it. Then we have seen some evidence. Now I'm going to go into the detail of the mechanism behind this. Once again, I'm not talking about the sources, not talking about the benefits. I am going to talk about the pro-inflammatory and anti-inflammatory behaviors of these molecules and how does this really work. So let's start. Imagine that you are eating some foods that have omega-3 and omega-6. These enter our digestive system. From the digestive system, GIT, these fats are absorbed, they become packaged up in the chylomicron, and then they're distributed in the body. Eventually, these fats, omega-6s and omega-3s, I'm not talking about omega-9 deliberately, I just want to stay focused 4, 6, and 3. These are delivered eventually to cells. So here, the omega-6 and 3, when they have been delivered to the cells, there are many functions that these can perform. For example, we can use them to produce energy. We can use them to produce the membranes of the intracellular organelle. We can use them for various enzymes that can work with the lipids. And the most important thing that is important for today's discussion is that the cell membrane itself is made up of phospholipids. So phosphates and lipids. And in those lipids, there are going to be polyunsaturated fatty acids, some of them omega-3, some of them omega-6, even omega-9 and more. This is a very important thing. So once these omegas are delivered to the cell would then take omega-3 and omega-6 and stitch them into the cell membrane, and more on that next here. So now what I've done is I've taken a piece of the cell membrane. So if I go back here, let's say this piece of cell membrane. I've taken that and I put that over here. The blue blobs over here are the phosphates. And then if you see, there are two legs attached with each phosphates. There are two lipids attached with it. One are these orange straight lines. These are saturated fats. So one fat chain that is attached is usually saturated. The other one that you can see has a little kink in it, has a little bend in it, that is polyunsaturated fatty acid. This one has double bonds that are present in it, and when those double bonds are present, they cause a kink in the fat molecule, and the benefit of that kink is that allows this fat molecules to kind of keep the cell membrane fluid. So these are important for the fluidity. Then the length of the fatty chains would also affect the fluidity. Cholesterol levels would affect the fluidity. So there are much more, but this is one aspect of it. And guess what? These kinks, these bent fatty acids are actually polyunsaturated fatty acid. That means they would be omega-6. Some of them are going to be omega-3, some omega-9 and more. Usually on the inner leaflet of the bilayer, so if you see, these are two layers. This is one layer, phospholipid, and a layer of that, which is now making another layer, binding with another layer. So these are also phospholipids, and these are lipids here. Phosphates are here, and so two layers are creating this sandwich-like structure, and this is called phospholipid bilayer. Of course, there is part of a layer, we call it leaflet, that is on the inner side of the cell, and then there is a part that is facing on the outer side. The inner leaflet has more omega-3 and omega-6s on it compared to outer leaflet, but that is just a detail which is interesting and nothing more than that. Now look at this one. In this cell membrane diagram, I have created numbers here. So imagine that this is omega-6, this is omega-3. Remember I said that these orange ones are, the saturated ones, so they are not omegas, they're just straight fatty acids. This is, imagine, another omega-3, 6, 6, 6, 6, 6, and 3. What happens is that when you have eaten fats that contain omega-6 or 3 and they are digested and they are delivered to the cell, then the cell would actually stitch them in their cell membranes, and this is where they are present. Then what happens? Now imagine that this cell receives an inflammatory signal. something that wants to induce inflammation. That may be a viral infection, bacterial infection, a fungal infection, some other kind of damage, some immune system cells sending signals, cytokine signals, but eventually the cell is receiving a signal to produce inflammation. When that happens, cell would activate an enzyme called cytoplasmic phospholipase A2, and this enzyme has many types. Again, I am only interested in the discussion of the omega-3 and omega-6 and their inflammatory and anti-inflammatory behaviors. So here what happens is, within the cell, imagine that this was a cell membrane. Within the cell, when the inflammatory signals arrive, this enzyme here, phospholipase A2 cytosolic C, is activated. When it is activated, it translocates itself to the cell membrane. It goes to the cell membrane. It was swimming and having fun within the cytosol of the cell, and it then translocated and bound to the cell membrane. Over there, as you can see, it is shopping from these omegas. Its job is to go and pluck, or in scientific terms we'll say cleave, meaning remove, cut. Its job is to go pluck or cut the omegas from the cell membrane. So of course, whatever omega you have been eating and whatever omega has become part of your cell membrane, that is the omega that it would work with, it would remove. Now, it is interesting that there would be some omega-3s it would come across, and there would be some omega-6, and their ratio would really depend that how many omega-6s it encounters versus how many omega-3s. And it's not just one enzyme, there are going to be hundreds of these enzymes running around in this cell membrane forest and plucking the omegas and removing them. Then what happens? These omegas are then handed over to another couple of enzymes, actually 3 enzyme pathways. I've only made 2 over here: cyclooxygenase pathways and lipoxygenase pathways. So I want to go back for a second here and introduce one more concept. When the phospholipase A2 goes and plucks the omegas or cleaves the lipids from the phospholipid membrane, if it is an omega-6 that it has plucked, it is just like, imagine that you are in a garden and there are many kinds of flowers, and somebody says, can you please pluck a flower? Whatever flower is in front of you, imagine you pluck it, that may be a rose or something else, right? So this phospholipase plucked, let's say 3. When it cleaves the omega-3s, it mostly leaves them as they are. It's just that it frees them from the membrane. So if it is a DHA or EPA omega-3, it would just remove them and it would just leave them free, but in the same state. On the other hand, when phospholipase A2 encounters omega-6, it will convert that into arachidonic acid. That is a very important and delicate point to keep in mind. So when the omega-6 is plucked and cleaved, it is not just freed. Instead, the same enzyme would further chew it out, further work on it, and convert that into arachidonic acid. Arachidonic acid in turn will help produce typically, it will help produce pro-inflammatory molecules, for example, prostaglandins and leukotrienes, etc. So here, the cyclooxygenase and lipoxygenase are working on whatever is freed by phospholipase A2. If it is arachidonic acid, then that would further make more molecules that are pro-inflammatory, and this cell and the surrounding cells are now going to get into an inflammatory state. On the other hand, if this friend of ours, the phospholipase A2, was cleaving more omega-3s, then the omega-3s will become released, and these omega-3s, when they work with cyclooxygenase and lipoxygenase and CYP450, they create metabolites which are anti-inflammatory. This is the backbone of our discussion today. So this means if you have been eating a lot of omega-6s, then a lot of your cell membrane is packed with omega-6s. So whenever there is a chance of producing inflammation for legitimate reasons, body is going to encounter these enzymes, are going to encounter more omega-6s, and so the resulting molecules that will be produced are going to be more pro-inflammatory molecules. That doesn't mean that omega-3 will not be encountered and anti-inflammatory molecules will not be made. They will be made too, but now relatively more production is happening of pro-inflammatory molecules. So you receive a signal and you respond with a lot of inflammation if there is a lot of omega-6 present in the cell membranes. So I have a quick test for you. Imagine that these are two people and we have taken their cell membranes. This person A, has, look at this, 6, 6, 6, 6, 6, and 6. These are all 6. On the other hand, the person 2 here has these 6 only. So the person 1 or person A has been taking more omega-3s, more omega-6s than omega-3s, so their cell membrane is packed with lots of omega-6s. On the other hand, person B has been taking lesser omega-6s or relatively more omega-3 as well and keeping a good balance of this ratio. Then they have, let's say, more omega-3s or a balanced set of omega-3 and 6s. Who do you think, if this person A or B becomes inflamed, gets an infection, who do you think will produce more response, inflammatory response? I'm hoping that you're saying that the person A will develop a stronger inflammatory response because they have more molecules which, when mobilized, will result in inflammatory metabolites. So this tells us that, number one, it is not that you take omega-3 today because you have inflammation and tomorrow you're feeling better. Yeah, sure you will. It is actually a lifelong activity to make sure that our cell membranes are not packed with omega-6s, but instead there is a balance of omega-6 and 3 in them. We do need inflammation as well because we have to handle states, viruses, fungi, bacteria, other conditions where we need inflammation. So it is not that we just want no omega-6s, but more omega-3 will be very useful so that when there is an inflammatory signal, our cells do not just explode with inflammation. So here are the lipoxygenase and cyclooxygenases. These enzymes, and they don't look like elephants, I just wanted to draw elephants. These enzymes will work with whatever you give to them. So if the phospholipase A2 went to the cell membrane, mobilized from there or cleaved from there the omega-6s, which then became arachidonic acid, and you give them to lipoxygenase and cyclooxygenase, then they would make more inflammatory metabolites in there. On the other hand, if the inflammatory signal came in, lipoxygenase, phospholipase A2 went to the cell membrane, there were a lot of omega-3s as well in addition to 6s. It released them. Those omega-3s will work with the lipoxygenase and cyclooxygenase and produce metabolites that are anti-inflammatory. So see the raw material. Do you have the matchsticks sticking somewhere, or do you have water that can take the fire out? So at the end, if we start thinking about, I'm going to repeat this part, if we start thinking about how to take omega-6 and 3 and what ratio, it really is dependent upon the body state and what are we trying to achieve. If a healthy individual is thinking about omega-6 and 3 ratio, then yes, our generalized food Western food has more omega-6s than 3, so then it is good to strive to reduce 6 and increase 3. If somebody is acutely infected, they may actually be benefiting from the omega-6 because they are producing inflammation. Trying to take away their inflammation at that time may not be beneficial, but we know that people in this state, we give them ibuprofen or other anti-inflammatories. So if that is the case, then omega-3s can be given here as well, but lesser omega-6, because omega-6 are already a lot mobilized. Then if somebody is in a chronic inflammatory state, that means they are mobilizing a lot of omega-6s and they are consuming a lot of omega-3s, and their balance is already tipped incorrectly. So in such individuals, with of course a doctor's advice, they can increase more omega-3, even prescription omega-3s can be given, and omega-6s can be reduced. Now, of course, at the end of the day, all of this should be done with your doctor's advice. This is not a medical advice. This is informational lecture to debunk, and not debunk, but to disentangle the idea of the ratios. Ratios is not a generalizable statement. Ratio would depend upon the state of the person who's thinking about it and their need. So with this, thank you very much. Please like, subscribe, and share. I'll do more talks in this area of inflammation, and if you would like to support this work, then there are links in the description and you can use them to support it. I would see you next time. Bye for now.